Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the second session of tonight webinar, Best of EULAR. Again, we have a very excited session about systemic lupus erythematosus, and now we have another excited session about most of the connective tissue diseases, scleroderma, mixed connective tissue disease, myopathy, and so on. The chairperson of this session is Professor Sami Bahlas. So I don't know what to say about Professor Sami. All of you, we know him. Professor Sami is our teacher. He is one of what can I say? That very nice personality. Everybody like him. He's a professor of medicine at King Abdulaziz University Hospital, and he is the head section of rheumatology department in King Abdulaziz University. He got a lot of publication, very active in research, excellent speaker. He got a lot of activities in the last, in the last 5 to 4 years. He is yearly giving or he's sharing rheumatology conference related to internal medicine and King Abdulaziz University. So without further delay, I will leave the microphone for Professor Sami. Welcome, Professor Sami.
Dr. Hanan, thank you very much for very nice introduction. I hope I can meet what you have said. You made my head big, Faraha. Thank you very much. I'm very thankful to you to ask me to chair this session. Very thankful to the Saudi Society of Rheumatology for very good activity that is very useful for all of us. And I'm happy to chair this session with very good, excellent colleagues, starting with Dr. Fahid Al-Anizi, who is the Secretary General of the Saudi Society of Rheumatology. He's well-known rheumatologist. He's assistant professor of medicine in Al-Majma' University. In the last 6 years, he's a consultant rheumatologist, and also he's the head of internal medicine in the Department of Internal Medicine in Al-Majma' University. He's certified in both rheumatology and internal medicine since 2015. This makes him now a senior rheumatologist according to our definitions. He's also a clinical and research fellow in SLE from University of Toronto. Dr. Fahid, he will talk to us about inflammatory myopathies and Sjogren mixed connective tissue disease. Dr. Fahid, tfaddal, the microphone is yours.
Thank you so much, Professor Sami Bahlas, about your introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. I would like to welcome all of you in the second day of the Best of EULAR. I would like really to thank Dr. Hanan Reis, the head of the president of Saudi Society for Rheumatology, for her great efforts and a great job for organizing the Best of EULAR. So this is my outline. I will talk about the, first of all, we'll start with the new treatment option of the patient who have inflammatory myopathies. So at the beginning, I would like to start with you with this study which published 2018, talking about the development of the new classification system for idiopathic inflammatory myopathies based on the clinical manifestation and myositis-specific autoantibody. So the main idea behind the study, just to looking for the phenotyping, biological and immunological criteria for this patient. So it was a retrospective cohort study. The database was collected from the French myositis network. Out of 450 patients, only 250 were included in this study, and all of them were tested for the different autoantibody. So after that, by the computer system which analyzed all of this data, so the result emerged for a cluster group. The first group, IMNM, mediated necrotizing myopathy. The second group, dermatomyositis. The third group, overlap myositis, and the last group, inclusion body myositis. So the conclusion of this study was to the criteria suggest to targeted the clinical and serological approach to identify the patient who have idiopathic inflammatory myopathies. So I will start with the first group regarding the IMNM. So what is the new here? First of all, I would like to talk about the pathophysiology of the IMNM. As we know, due to the deposition of the autoantibody anti-SRP and anti-HMGCR in the surface of the muscle cell, that will activate the complement cascade, which eventually will form what we call the membrane attack complex, MAC. And this one, it's implicated as a pathophysiology, can cause necrosis and muscle death, which can be reflected by high CK in the blood. So the study, we have studied talking about the role of the xylocoplin. It is phase 2B for 24 patients. It's ongoing study till now, is not finished, and till now we don't have a lot of result about the study. But the xylocoplin, it is the new medication targeting the complement. So we are dealing with the anti-complement medication for the IMNM. They are divided into groups. The group who been on the 0.3 milligram per kg subcutaneous daily, and the other group, the placebo group. Honestly, hopefully we will see the result in the next EULAR 2021. But just I would like to let you know that xylocoplin now has been used to the another study about the patient who have myasthenia gravis, that they share the same idea. So the primary result from this study, it is positive, and it has a promising, excellent result. So the next slide, or the next cluster group, I will talk about the inclusion body myositis. So part of the, all of you, you know the pathogenesis of the inclusion body myositis. We have no idea about it, but what we know, there is two possibilities behind the pathophysiology. The first one, the inflammatory process, and the second one, the degenerative process. So we are looking for the medication that targeting these two ones. We have the study talking about ripamycin, sirolimus, in the inclusion body myositis. It was randomized, double-blind, placebo-controlled study, phase 2B study. Divided two groups of patients, 22, they had been used on ripamycin, and the second group on placebo. And the primary endpoint after 1 year. So the assessment of the outcome of this study, to looking for the strength of the quadriceps muscles, also to looking for the strength the other muscles, and to looking for the HAQ score, pulmonary function test, and the fat replacement in the muscles, which determined or reviewed by the MRI. So we have the primary result about the study. Unfortunately, the study, it wasn't achieved the primary endpoint, which means the patient they have still they have weakness in the quadriceps muscles, similar to the placebo group. But on the other hand, there is much improvement in the other muscles. There is improvement in the HAQ score. There is least muscles, fat muscles replacement, which required by the MRI. Also, there is improvement in the pulmonary function test. The next slide, I will talk about the dermatomyositis. All of us, we know that the interferon, it's implicated as a pathogenesis in the mechanism of dermatomyositis, and also we have an in vitro study which document that JAK pathway inhibitors has been reported to decrease the type 1 interferon. So there is a new study still is not started, which talking about the role of the baricitinib in refractory dermatomyositis. When they started the patient with the 4 milligram, unfortunately, till now, studied the phase 2B, and hopefully we can see the result in the next EULAR. So I found this study, which and the abstract, which is talking about the effectiveness of plasma exchange therapy for anti-MDA5 antibody positive refractory interstitial lung disease. So the objective of this study to evaluate the effective of the plasma exchange on the survival of the patient who have rapid progressive ILD with positive anti-MDA5. So regarding the methods and the result of the study, 11 patients were who had refractory to intensive immune suppressive therapy. 7 of them they received plasma exchange, and it was labeled here as PE group, and 4 of them they didn't receive plasma exchange and were labeled as non-PE group. So the result of the study showed that the first year survival rate of the PE group was higher than of the non-PE group. So the conclusion of the study, the plasma exchange may be considered in refractory rapid progressive ILD patient who has positive anti-MDA5 antibodies, and also it could be used in patients with active infection who were immune compromised by the immune suppressive therapy. Also, the intensive immune suppressive therapy improved the survival rate in rapid progressive ILD patient, but there is still 20 to 30% mortality case. So the last group, I will focus on the anti-synthetase syndrome. Honestly, I couldn't find any new data talking about the new treatment option about the anti-synthetase syndrome, but I found this a nice future, hopefully future study. They will start in September 2020. Just I would like to show you the proposal of the study, which talking about the head-to-head study about the tacrolimus and induction therapy cyclophosphamide followed by maintained with the amioran. The idea behind of this study, which is the talking about the different study segments. For example, the North American and the Japan, they prefer to use tacrolimus, but in the European group, they prefer to use the induction therapy cyclophosphamide followed by the tacrolimus. So regarding the conclusion of my first outline, regarding the IMNM xylocoplin, which is the new items used to blocking the complement system, hopefully we'll see a good result. Sirolimus and the patients who have occlusion body myositis, overall it's better than the placebo. For feature-wise, there is a rule of JAK pathway inhibitors in refractory dermatomyositis, and regarding anti-synthetase syndrome, hopefully we can see the study future. Regarding my second outline, I will talk about the new treatment of Sjogren's syndrome. So, regarding the pathophysiology of Sjogren's syndrome, as we know, it is a little bit complicated because it involves many of factors and cytokines and cells which is implicated in the disease. So the main idea of this outline or the main idea for the future strategy management for the patient who have primary Sjogren's syndrome to targeting the immunophenotype for each one. So first of all, I will talk about the interferon. So we have a good data before talking about the presence or the implicated of the type 1 interferon in the primary Sjogren's syndrome. And what we have now, new data, which is the lab data or experimental data, can be linked between the IL-7 and type 2 interferon. So we have, before the study, French study, approved that there is the patient who have primary Sjogren's syndrome, they have increased the serum level of the interleukin-7. So here the idea of the experimental study, the salivary gland epithelium cell can secrete IL-7 after stimulated by different type of the interferon. Then the IL-7 will bind with the T cell, can be stimulated to secrete the interferon. So that's what we call a loop of activation. To go more deep in this, to go more deep in the experimental study, so they took a salivary gland biopsy and they found there is a high expression of interferon and IL-7. Then they start with the anti-IL-7 receptor blocker. Then they found the conclusion was there is significant decrease of the interferon. So the main idea behind the study, there is a future for the blocking the IL-7 receptor. The second immunophenotype, I will talk about the T cell. We have before two study, it showed the negative trial of a primary endpoint SDI by using the abatacept when targeting the T cell, and also we have the This is the second negative trial for secondary efficacy for ESPRI when have been used the abatacept to block the T cell. But we have a new study which tackled the abatacept treatment for patients with early active primary Sjogren's syndrome, and it is the open label extension study. So the main outcome of the study to look for the disease activity is dye and ESPRI, to looking for the glandular function, also to looking for the serological outcome. So regarding the result and the conclusion of the study, both dye and ESPRI improved significantly during 48 weeks of abatacept treatment. There is significant improvement in the glandular function. Also, there is decrease in the biological activity. But also, regarding the placebo-treated patient, also shows significant improvement in both indices, but further improvement after switch to the abatacept. We have also another concept to targeting T cell and interferon by using a combination of the hydroxychloroquine and leflunomide. So we have this study which show for us the synergistic effect of combination between leflunomide and hydroxychloroquine in patients who have primary Sjogren's syndrome. There is significant decrease in the gamma globulin in general. That means there's an inhibition of the beta cell activity. So, and also we have a study, an Utrecht study, which is for the main concept. They use the combination between the leflunomide and the hydroxychloroquine, and at 24 weeks we can see improvement in the S-dye and improvement in the ESPRI. Also, there is symptomatic wise, there is significant improvement in the fatigue and pain, and also there's increase of the unstimulated whole salivary flow. Regarding the third phenotype targeting the beta cell, so we have a new experimental data about the link between the epithelium cell and activation of the beta cell. So this is a higher survival and activation of beta cell in co-culture with sub-epithelium glandular salivary gland versus placebo. So we have now phase 2A trial targeting anti-CD40. The study about to compare two doses of the same medication. The first one 3 milligram per kg subcutaneous, and the second one 10 milligram per kg IV, and the primary endpoint in the week 12. So this is a study show honestly and a significant improvement of the S-dye when has been used the medication of 10 milligram per kg IV, which is a promising good future for the patient to treat the patient with the primary Sjogren's syndrome. Regarding this is the same thing. Okay, regarding we have a good data talking about the role of rituximab in Sjogren's syndrome, but the new thing is that there is an increase of the serum BAFF after treat the patient with the rituximab. So the idea we are looking to targeting BAFF receptor. Before of that, I would like to share with you this interesting paper talking about 3 patients with Sjogren's syndrome and the cryoglobulinemia vasculitis refractory to different lines of treatment. So those patients, they treated by a combination of the rituximab followed by pilimumab, and honestly, it showed for us an excellent efficacy and with positive good result. So we have a new agent, they call it ianalumab, which is mainly targeting BAFF receptor as anti-BAFF receptor antibody. It can be work as a combination between rituximab and pilimumab. So ianalumab is mainly can inhibit the cell survival and can be induce the cell death. So regarding the result of this study, we have the primary endpoint at week 24, which is the dose-related result. So the efficacy has been significantly seen when they use the dose of 300 milligram. So The SDI change from the baseline over time up week 24 reveal statistically significant dose response when had been used with a 300 milligram. Also, in the efficacy at week 24 as secondary analysis show there is statistically significant difference for inelimab on 300 milligram versus placebo. Regarding the last immunophenotype, I would like to talk about it, which is the plasma cell, and we have a good data suggest the link between the concentration of the plasma cell in the patient who have a primary Sjogren syndrome, and we have for the future wise we have perspective of targeting plasmablast and the plasma cell by using all the new drugs that working in multiple myeloma. So this is the future for the also for to treat the patient with the different modality of medication which has been used now for multiple myeloma. This is I would like just to summarize for you the current randomized controlled trial for patient in Sjogren syndrome, and I already mentioned some of them in my presentation. For the future wise, there is a big a trial, they call it the necessity clinical trial. They will start with this trial in 2021, and the main inclusion criteria for the patient based on the disease activity, S-type and ESPRI, and the medication they would like to use it mainly plus placebo, hydroxychloroquine, leflunomide, and Cellcept. Regarding the conclusion of the second outline, the classification based on the immunophenotype of the disease has improved, so we have to select our drugs dictated to each of these pathways. The third outline of my topics, I will talk about the new art of phenotyping and treating Sjogren syndrome. We have around now 20 new autoantibodies to diagnose the patient with the primary Sjogren syndrome, and each one it can be linked with the clinical correlation. And also, just I would like to show you there is a new system, they call it Harmonics. The Harmonics, it is the national and international big database cohort on primary Sjogren syndrome. So just I would like to link between this slide and the previous slides. So the main idea of this outline is to correlate the clinical phenotype of patient with the Sjogren syndrome, which can be influenced by the demographic features like age and gender, and also the presence or absence of the autoantibody. For example, here I can show you some data of this big cohort. Around here we can see clearly that the male patient have more lymphoma than female. Also, regarding the patient who has been diagnosed with the primary Sjogren syndrome at age less than 35, they have lymphoma more than the middle age. Also, they have more leukopenia and low C4. Also, regarding the age, the patient who been diagnosed with primary Sjogren syndrome in age more than 65, they have more lymphoma compared to the middle age. Also, the patient who have a cryoglobulinemia vasculitis, they have more lymphoma than others. And the last thing regarding the patient who have absence of the triple autoantibody or quadruple antibody show less incidence to have lymphoma. So the main idea about this concept that the demographic and autoantibodies in Sjogren syndrome can differentiate the risk for lymphoma development, as clear here in this picture. Also, we have a part of the same idea. There is another cohort study talking or tackled about the geolocation and ethnicity. So we can see here in the white patient, the age of diagnosis, we can see it is older than any other different group, and at the same time they have less anti-RO if we compare with the other groups. And the others comment, for example, the Asian patient, they have least weaker symptoms if you compare with the other group. And regarding this study, which the main idea from this study, cohort study, it showed for us that around 20% of clear systemic manifestation of the patient who have a primary Sjogren's syndrome is out of SDI. That's why it should be reassessed again. So the conclusion of the third outline, the clinical phenotype of patients with primary Sjogren's syndrome can influence by demographic characteristic features and the presence or absence of autoantibodies. And we require now multiplex approach to define new group of patients. Regarding the fourth or the last outline in my presentation, just I would like to focus in some abstract, interested abstract. Just I would like to share it with you. We have here a clinical, we have here a good study talking about the clinical and histological spectrum of anti-MI2 dermatomyositis. So this study just to show for us any difference in the clinical or histological finding between the patient who has positive anti-MIO2 or negative anti-MIO2 in dermatomyositis. So 95 patients were included in this study. 23 of them, they have positive anti-MIO2 antibody. Regarding the result or conclusion of this study, all patients who have positive anti-MIO2 show the high muscles or muscles involvement, and at time of diagnosis they have a high CK compared with the negative group. On the other hand, the prevalence of the interstitial lung disease in the positive MIO2 lower than a negative group, negative MIO2 group patient. And regarding the biopsy, we can see here the prevalence of the necrotic and degenerative myofiber, which can be seen more in patients who have positive anti-MIO2 dermatomyositis. So the conclusion of this study, the patient who has a positive anti-MIO2 dermatomyositis represent a specific subset with a higher muscles damage, and also they have endomysial macrophage infiltration. The other abstract I would like to show to you. This one, honestly, that's why we don't like to miss the other modified risk factor for our rheumatology patients. So I can find this study which talking about is the cardiovascular risk in inflammatory myopathies underestimated. So the main idea of this study to compare the incidence of the cardiovascular event in patients who have idiopathic myopathies, and is it can be influenced by age or gender or ethnicity. So 159 patients were included in this study, and the result and outcomes of this study showed that the incidence rate of atherosclerotic cardiovascular event showed twice higher than compared with the other group, and also we have an statistically difference, the incidence rate that's common in male than female. Also, it has been associated with the disease duration with a pay reduction 0.7 per year. So the conclusion, the answer is yes, the cardiovascular risk is underestimated in patients who have idiopathic inflammatory myopathies, and they recommend to start statin, particularly in the first year after diagnosis. The last abstract I would like to share with you, which talking about the status of lymphocyte and the peripheral blood of patients with the primary Sjogren's syndrome and their change after receiving the combination therapy. So this is the objective of the study, just to explore more about the pathogenesis and to evaluate the therapeutic effect by comparing with the change in the lymphocyte before and after the treatment with the combination therapy. So mainly we are looking for the lymphocytes and also looking for the regulatory cells, which mean here as triggers. Regarding the result of this study, which show the absolute number of the triggers regulatory cells as well as T or NK cells were significantly lower than those in the health control study, and after the combination treatment, there is a high, the number of the triggers was significantly increased. So the conclusion of the study, the decrease of peripheral triggers play an important tool pathogenesis in the primary Sjogren's syndrome, and by using a combination therapy, it can be promote the increased triggers and may be helpful for the recovery in the primary Sjogren's syndrome. With this slide, I would like to finish my presentation, and I would like to give the microphone for the chairperson, Professor Sam Bahlas.
Okay, Dr. Fahid, thank you very much. Very nice summary, update, good future for treatment for Sjogren, and also understanding more about myositis. Thank you very much for this summary. Very good update, really good effort. I really enjoyed it. Thank you. Now we move to our next speaker, who is Dr. Walid Hafiz. Dr. Walid Hafiz is Assistant Professor of Rheumatology and Internal Medicine in Al-Qura University from Mecca. He's a consultant rheumatologist in arthritis and rehabilitation in Noor Hospital in Mecca. He has a clinical fellowship in adult rheumatology from Toronto, Canada, and also clinical research fellowship in Toronto Scleroderma program. And he's a board member of the Saudi Society of Rheumatology. Dr. Walid Hafiz will give us update about systemic sclerosis. Dr. Walid, تفضل, the microphone is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman, for this warm introduction. It's an honor and a pleasure to sit here before you to talk about a few stuff in systemic sclerosis. I would like to extend my appreciation and thanks to the President of the Saudi Society of Rheumatology, Dr. Hanan Al-Rayis, and congratulate her for the marvelous effort in trying to bring this meeting into reality. I also want to thank the chairman of the Best of EULAR 2020, my dear friend, Dr. Fahid Al-Anizi, for giving me this opportunity. And by the way, congratulations for this very comprehensive presentation. I want to thank Dr. Khalid Abdul Shakur from Pfizer and the organizers for helping me put the slides of this presentation together. So over the next 20 to 25 minutes, I will be walking you through the best that I think was presented at the EULAR 2020. And I think that systemic sclerosis was extensively presented at this past meeting, with approximately 70 to 75 research projects that added new knowledge in the basic translational as well as the clinical aspects of the disease. In this slide, I share with you my pick of the abstracts that I hope will add new insights in our care of systemic sclerosis patients. So as you can see in this slide, the selected abstracts cover different areas of the disease, starting with clinical features, passing through some researches in the translational medicine, putting some lights on the preclinical systemic sclerosis period, and then moving on to the diagnostic and some prognostic studies, and then ending up with a few studies on treatment. At the end, I will also introduce you to a new patient-reported outcome measure that we think will be adopted in the scleroderma research clinics in the near future. So let's start. So my first pick for you is a cohort that was presented by a study group from Toulouse in France, in which they studied the nervous system involvement in systemic sclerosis. As you all know, that we usually don't ask our systemic sclerosis patients about CNS manifestations, because we think that probably they don't experience these manifestations. In fact, if you open the textbook of scleroderma, you won't find a chapter that describes the CNS manifestations in these patients, like other organ systems, like gastrointestinal involvement, as well as lung involvement. So what happened, the aim of this study group was to determine the frequency, clinical characteristics, some associated factors, as well as the outcome of both peripheral as well as central nervous system features in patients with systemic sclerosis. So they recruited patients from the Toulouse systemic sclerosis cohort. They were about 462 patients, and then they followed them for about 1 year. During that period, they noted that third quarter of the recruited patients had no nervous system involvement. However, 29 patients showed symptoms compatible with central nervous system involvement, and 82 showed peripheral symptoms. Now, among the peripheral symptoms, carpal tunnel syndrome was experienced by approximately 63% of patients, and I'm not sure if this was secondary to central nervous, nervous system involvement, or it was just because of the local pathology and the compression that these patients experience because of the deposition of the collagen and fibrosis in their skin. This peripheral symptom was followed by other symptoms such as polyneuropathies, trigeminal neuropathy, and occipital neuralgia in 5 to 15% of the patients. On the other hand, CNS involvement was, the central nervous system involvement was evident as approximately half of the patients experienced headache, followed by seizure as well as cerebral vasculitis in up to 10% of the patients. Now, the study group conducted the multivariate Cox regression analysis in an attempt to identify any possible associated factors. And what they noted is that patients who experienced peripheral symptoms were anti-SCL70 positive. They had BMI of more than 23. They had musculoskeletal symptoms, and they had low ejection fraction. On the other hand, patients who had central nervous symptoms, they were of Caucasian ethnicity. They had anemia, and they were middle age or elder, and they had a positive anti-PM SCL, which is an antibody that is seen in patients with scleromyositis. So the authors concluded that both peripheral and central nervous system involvement is not uncommon in systemic sclerosis, although these symptoms may not appear to increase mortality. However, they can have an impact on the functional prognosis. Okay, my next pick, again in the clinical features area, is an analysis of the EUSTAR cohort. And EUSTAR is the largest European scleroderma registry, in which the study group tried to see if there is any association between scleromyositis and cardiopulmonary involvement. Now, scleromyositis refers to the overlap syndrome in which patients have an overlap of scleroderma as well as polymyositis. So the objective of this study group was to evaluate the cardiac involvement in anti-PM-SCL positive patients in the EUSTAR cohort. Now, it's worth to mention that up to 25% of scleromyositis patients, they tend to have positive anti-PM-SCL antibody. So they recruited patients who tested for this antibody, and then they divided the patients into either antibody positive individuals and antibody negative individuals. Now, if you can look at this schedule, that these outcomes were not statistically significant. There was no statistically significant difference among both groups, with the exception of the systolic pulmonary artery pressure. However, when the positive antibody was linked to the myositis, which was in form of elevated CK, this Cox regression analysis clearly revealed that patients who have positive anti-PM-SCL antibodies as well as CK elevation, they show higher frequency of cardiopulmonary involvement. With that, the authors concluded that these patients are the one at risk. So the learning point out of this study, I think, is that if you have patients who present with both scleromyositis or the overlap syndrome, I think they're the ones who will need some sort of like extra or more close monitoring of their cardiopulmonary symptoms. Okay, so let's now move on to the translational part of the researches that were presented at the EULAR 2020, and I will pick this one, in which the authors studied the impact of placental factors on pregnancy and fetal outcomes in patients with systemic sclerosis. We all know that our systemic sclerosis patients are at an increased risk of obstetric complications during pregnancy. So the study group aimed to analyze the placental alterations with a focus on the role of inflammation. Now, they analyzed the histopathological and immunohistochemical substances from the placenta from 8 pregnant women with systemic sclerosis, 16 patients with other rheumatic diseases, and 16 healthy controls. What they found that these inflammatory cells, CD3 plus, CD11C plus, as well as CD68 plus, and sorry about the typo mistake here, these are all inflammatory proteins or cells that activate both the cytotoxic T cells as well as the T helper cells. They can also activate the adaptive immune response. So all these substances were elevated in patients with rheumatic diseases. They also found that a hepatocyte growth factor, which is linked to the restriction of the embryonic organ growth, this factor was also elevated in patients with rheumatic diseases, and CCL5, which is again a chemotactic cytokine that is responsible for the activation of cytotoxic T cells. This cytokine was also found to be elevated in patients with systemic sclerosis, plus it was linked and was correlated to the histological velitis, and velitis refers to the inflammation of the surface of the placenta. So the authors concluded that the higher number of these inflammatory cells, especially the hepatocyte growth factor as well as CCL5, could play a role in the pathogenesis of the obstetrical complications, in a hope that identifying some treatment to these druggable molecules in the future may help halt or delay the progression of or the development of obstetric complications in patients with systemic sclerosis. My other pick in the translational studies that were presented at the EULAR 2020 is this one, in which the authors studied the correlation, the biological correlation of some of the proteins from the bronchoalveolar lavage and radiographic features in scleroderma lung study 1, in which they studied certain cytokines from the bronchoalveolar lavage that was obtained from approximately 100 patients from the scleroderma lung study 1 trial. And what they found that there were few cytokines that positively correlated with the radiographic features of the interstitial lung disease, namely ground glass opacities. And on the other hand, there were a few cytokines that negatively correlated with the progression or the development of the ground glass opacity. With this, the authors concluded that these bronchoalveolar lavage proteins or cytokines may serve as important mediators of inflammatory and fibrotic processes. And again, for like the future implication of this translational study, if some of the therapeutic options that will be developed in the future can target these druggable molecules, it may help again halt or prevent or delay the development of the very common interstitial lung disease in patients with systemic sclerosis. Now let's switch gears to the preclinical systemic sclerosis. In this study that comes from Brazil, the study group tried to identify predictors to progression to systemic sclerosis from secondary Raynaud's phenomenon. And what they did, that they recruited patients who had at least one systemic sclerosis manifestations along with Raynaud's phenomenon, however, without skin thickening. And then they analyzed the predictors for the development of systemic sclerosis. So it was a cross-sectional single center analysis that recruited patients for the past 10 years, from 2010 to 2019. And patients who were recruited had Raynaud's phenomenon as well as one systemic sclerosis manifestation, with the exception of skin thickening. So there were 217 patients who were classified into either systemic sclerosis based on the 2013 ACR-EULAR classification criteria for systemic sclerosis, or UCTD, in which 64 patients qualified for this diagnosis, and then they compared them. So what they found is that patients who present with puffy fingers and patients who have higher systemic sclerosis score based on the 2013 ACR-EULAR classification criteria, they are the one that are prone to progression to systemic sclerosis. So again, the learning point from this study, that if we see patients who have puffy fingers and they have a higher systemic sclerosis classification criteria score, even if they don't have sclerodactyly or skin thickening, they are the one who are going to progress to systemic sclerosis down the road. So probably more attention and close monitoring is warranted in these patients. My other pick in the pre-clinical systemic sclerosis is a study that studied biosamples from at-risk systemic sclerosis patients. And the patients were taken from the famous VEDOS study. So VEDOS actually stands for the Very Early Diagnosis of Systemic Sclerosis. This is a study that was authored by Oliver Distler, and it was published in 2019, in which they also identified some predictors for the development of systemic sclerosis, and they namely named puffy fingers as well as positive autoantibodies, either anti-centromere or anti-SCL70 antibodies. So in this study, the authors aimed at assessing the sera, skin biopsies, as well as skin fibroblasts, and they cultured them for possible biomarker signs of systemic sclerosis. And so the methodology behind that, they took these samples, and what they found that interferon score was actually elevated in the at-risk patients, similar to the patients who had early diagnosis of systemic sclerosis, and this was statistically significantly different from patients who were healthy controls. They also found that skin biopsies from the autoantibody positive patients showed increase in the collagen bundles as well as fibroblasts, both of which can hopefully work as biomarkers for the development of systemic sclerosis and progression from preclinical disease to systemic sclerosis. My next pick is in the diagnostic field, and in which the group of this study aimed at assessing the performance of high-frequency ultrasound in the assessment of skin involvement. Now, what they mean by high frequency is, frequency of 10 megahertz or more, because this frequency or more is very good at scanning and screening superficial structures, and that's why this type of ultrasound is widely used in the clinical practice of dermatology. So the authors of this study scanned dorsal finger, hand, forearm, and the upper arm skin of the patients with diffuse cutaneous systemic sclerosis subtype. This was done at different disease stages using the high-frequency ultrasound, and this was compared to those from healthy controls. And as you can see, that skin thickness was clearly different from those with healthy controls. And when they were compared to the classic modified Rodnan skin scoring system, the skin thickness on the ultrasound positively and significantly correlated with the skin scoring using the modified Rodnan skin scoring. So I think in the near future, similarly to synovitis, skin thickness will also be one of the signs that will be assessed with the bedside help of the ultrasound. So this is a study on the prognosis. Again, this is a French group from Toulouse city from France, and they tried to assess for possible predictors of mortality in systemic sclerosis, and they recruited patients from from two centers from the same city, Toulouse, and patients were from 2000 to 2018, so a good time. And they ran some multivariate Cox regression analysis to assess for possible predictors of mortality in systemic sclerosis. And what they found that males gender, diffusion lung capacity of less than 70 or less, cardiac involvement, and CRP of more than 5. All of these work as independent predictors of mortality, along with the well-known ILD and pulmonary arterial hypertension. So the learning point out of this study that if you have a patient with systemic sclerosis and that patient has one or more of these independent predictors, I think that patient would warrant more follow-up and close monitoring in a hope or in an attempt to delay mortality as much as possible. Okay, so now I will move on to the therapeutic, and I think we're all interested in these types of studies more. So the first study here is the study that was presented by Danish Khanna, and he presented results from the long-term extension of the RISE systemic sclerosis study. We all know that a RISE systemic sclerosis study was a randomized trial of riociguat in patients with early diffuse cutaneous systemic sclerosis. We all know that riociguat is a soluble guanylate cyclase a stimulator that is approved for the treatment of group 1 pulmonary arterial hypertension. This is the type of pulmonary arterial hypertension that we have in our connective tissue disease patients. So this medication is already approved for pulmonary arterial hypertension. So this medication was tested in diffuse cutaneous systemic sclerosis patients. However, the primary endpoint, which was change in the modified Rodnan skin score from baseline to week 52, unfortunately, it was not met. However, in the long-term extension of this study, the authors noted that patients continued to show a reduction in the modified Rodnan skin score. However, this reduction was very low and was not considered significant, but numerically it was counted. And as you can see that, for example, only 70% showed more than 60% regression in the skin sclerosis, while only 24 showed more than regression in skin sclerosis by more than 60%. So the authors concluded that although this medication has not shown significant reduction in the skin sclerosis of patients with systemic sclerosis, however, this can be one of the therapeutic weapons in the back of our head if we're having a patient who has both pulmonary arterial hypertension secondary to systemic sclerosis as well as skin sclerosis. Okay, my next pick in the therapeutic studies is a new study that was recently presented at the EULAR 2020, and it studied the efficacy and safety of romilcimab in diffuse cutaneous systemic sclerosis. So this is a phase 2 study. Romilcimab is an engineered humanized Ig4 antibody that binds and neutralizes both IL-4 and IL-13. So basically, it's an IL-4 and IL-13 inhibitor. This study was a randomized, placebo-controlled study in which the primary endpoint was mean change in the MRSS at week 24, and the secondary endpoint was mean change in the lung function. And as you can see from the baseline demographics, that both study groups were very similar with no statistically significant difference among them. And it's worth to mention that both study groups received background immunosuppressive therapy in an equal number. So let's move on to the results of this study. So I'm happy to mention that the primary endpoint was met when they noted an absolute change in the modified Rodnan skin score by almost 5 points in the treatment group compared to 2.5 points in the placebo group. This change was considered statistically significant, although they did not notice this statistical significance in the secondary or endpoint. However, there was numerically less decline in the forced vital capacity in the treatment arm compared to the placebo arm. So having said that, I think romilcimab again is one of the new anti-fibrotic therapies that will hopefully join the antifibrotic treatment family in the near future, but I think it will still need more studies and phase 3 and phase 4 studies in the near future. The last pick in the therapeutic studies is again results from the focused trial that was again presented by Danish Khanna. And as you all remember, that focused trial, unfortunately, it was a negative study. It assessed the safety and efficacy of subcutaneous tocilizumab in patients with systemic sclerosis. So what they noted that patients continued to show numeric improvement in skin sclerosis beyond 48 weeks of the study until 96 weeks. And they also noted that patients in both treatment and placebo arm continued stabilization in their lung function, especially in those who were shifted from placebo to enter the open label tocilizumab group. So again, the same thing that was applied on the riociguat, I can say that although tocilizumab was not shown to be statistically, significant in terms of reducing the skin sclerosis as well as lung stabilizing or improving lung function. But I think with the very few medications that we have to treat our patients with systemic sclerosis, I think this is also one of the medications that will be in the treatment algorithm, and that is what is done nowadays at the University of Michigan by Danish Khanna and his group. Okay, so my last abstract is I would like to introduce to you the new patient-reported outcome for systemic sclerosis patients, and they named it ScleroID. So what they basically did is that they asked the scleroderma patients to determine 17 health dimensions that are of important or great concern to them, and then they tried to prioritize these 17 health dimensions by choosing 10, like top 10 health dimensions with the help of 100 patients. And these top 10 health dimensions that were selected by the patients were the following: Raynaud's phenomenon, hand function, upper GI involvement, pain, fatigue, lower GI involvement, limitation of life choices and activities, body mobility, breathlessness, and digital ulcers. They asked patients to quantify all these health dimensions on a score of 0 to 10, where 10 is like worse, and then they validated this patient-reported outcome and correlated it with different patient-reported outcomes that we mainly use in the scleroderma clinics, mainly the patient global assessment as well as the scleroderma health assessment questionnaire. And luckily that this new patient-reported outcome measure greatly correlated with both of these patient-reported outcomes, and the authors concluded at the end that this patient-reported outcome measure is a validated one, and it is specifically developed for patients with systemic sclerosis. It captures the overall disease impact of systemic sclerosis. It showed excellent correlation with other like PROMs, and it has good validity as well as reliability, and it showed better sensitivity to change when compared to the other patient-reported outcome measures. So, Mr. Chairman, ladies and gentlemen, with this, I come to the conclusion of my talk. If you allow me to wrap up my presentation in less than 1 minute, I can say that we are now improving in our understanding of systemic sclerosis from all its perspectives, clinical features, diagnostics, translational part of this, as well as therapeutics. And I always say that systemic sclerosis stands today where rheumatoid arthritis was like 10 to 15 years ago. And I'm very happy to see that more and more antifibrotics are being introduced into the research and clinical trials, all of which hopefully is going to provide our patients with a brighter future and make our life easy. Thank you very much.
Thank you, Dr. Walid. Very nice trip from basic to clinical and systemic sclerosis. Very interesting talk and effort. 2020 has made a lot of changes in a lot of diseases, as we can see, and one of them is systemic sclerosis. Thank you again for both of you, and I think we open the floor for discussion. We'll start by Dr. Fahid. A question for you, if they want to know if the availability of the monoclonal antibodies in Kingdom of Saudi Arabia.
Sorry, Sami, your question again?
Availability of all these monoclonal antibodies.
Because as we know, this is all of this is studied is the new released data, and still they are ongoing in the process of the study. Not all of them, they are finished. Most of the new strategy management of the Sjogren's syndrome, for example, because still the study is still in the process, that's not finished. So even the worldwide is not available, not yet at this due time. So no, we needed just a time after all the studies finished and published. Then after that we can see.
Dr. Walid, for the CNS involvement and scleroderma, would we also be able to correlate the headache with the anemias, since the headache was more common in the anemic patients?
Oh, definitely. I mean, these types of studies are usually either cross-sectional or cohort studies on a short period. So symptoms like headache, depression, carpal tunnel syndrome are very variable, and more than one disease can actually, or more than one pathology can contribute to the occurrence of this symptom. So I'm not sure if the authors of the study controlled these variables, because this was not mentioned in the study. However, it's really worth to do that should we do something like this in the near future to control the other confounding variables that might affect the end result of the study.
Dr. Fahid, the classification of myositis that was proposed, there is no class as pure polymyositis. Where would you put it? In the overlap myositis?
Yes, sir. Yes, they put it in the overlap myositis because, as you know, because there is a lot of the autoantibody. That's why we have a lot of the a new definition of the disease. So they put it in the overall myositis, and also because this is the if we would like to compare or just to mention the old classification for myositis, it will take a long circle to include in more than one of the cluster. For example, the inclusion by the myositis and the overlap myositis. So with this, I mean, a new cluster of a group, they prefer to put it mainly in the overlap myositis.
Okay. Dr. Walid, in the view of the finding of the study looking into high-risk patients to progress to systemic sclerosis using ACR EULAR criteria, how do you think we can use the finding of this study to develop a national screening program in Saudi Arabia for early systemic sclerosis patients?
I mean, this is an amazing question, and we're all hoping that, you know, in the near future we reach to this level. I think basically is by first of all creating systemic sclerosis registries like all over Saudi Arabia, and this is actually the intention and the direction that the Saudi Society of Rheumatology is moving forward to, and then trying to pick patients who are either in the early disease phase, or maybe they are in the preclinical phase. They usually present as either preclinical systemic sclerosis or maybe like UCTD. So we can, hopefully with the establishment of these scleroderma research clinics across the kingdom, we can actually recruit these patients and capture them as early as possible, in a hope that we can prevent the progression of their disease from preclinical disease to the full-blown picture of systemic sclerosis.
Again to you, Dr. Walid, with the results of the tocilizumab, where would you put it in your treatment when you treat scleroderma?
So, with the very little experience that I have, I would say that I have 1 or 2 patients that I'm using tocilizumab for their systemic sclerosis, but it was difficult for me to get it. But I was lucky that these patients had actually musculoskeletal involvement. So this is how we got this, medication approved for them. But if you look at the algorithm that is presented by Danish Khanna and his group, the group that actually ran this study, they usually put tocilizumab in patients who either show subclinical interstitial lung disease or maybe like early interstitial lung disease in patients with systemic sclerosis, in a hope that instituting this medication at early as possible might help delay the progression of this disease in the future.
Dr. Fahad, you said there is a study suggesting giving lipid-lowering agents to myositis patients.
Yes.
Right?
Yes.
Are you worried about the rhabdomyolysis or about the high enzymes, muscle enzymes in these patients? Are they prone to this complication?
Honestly, Professor Sami, regarding the study, they didn't talk about the side effect of the study. The main idea of the study, they are talking about the risk of the cardiovascular disease and how we can prevent, especially in the first year of the diagnosis. If we look for the recommendation with the low dose of the study, so to use or looking for the side effect of the statin for this such patient, it would be like any other patient who have been used. But honestly, regarding the study, they didn't mention about any side effect about the use of the statin after giving the patient for the infected.
Dr. Walid, we know that the skin softens in systemic sclerosis. So how would you attribute this improvement? To the intervention of the drug or the natural history of the disease?
So this is almost, a challenge in most of the clinical trials in systemic sclerosis, that we never know whether the softening of the skin is due to medication effect or because of the natural progression of the disease. And that's why if you look into the clinicaltrial.gov, you will see that there were many clinical trials that they tried to test the skin involvement in systemic sclerosis, and most of them actually failed to show any positive results. The reason behind that is that they actually involved patients who probably had, in a way or another, burnt out disease in terms of their skin involvement. So the most recent studies, at least for the past 2 years, what they're doing, that they're recruiting patients who have actually low skin scores. What I mean by that, a modified Rodnan skin score of 10 or less. So by this, we hope that we will be able to link the improvement in the skin to the medication rather than the natural progression of the disease. That's number one. The other thing is that usually the natural, improvement of the skin sclerosis in patients with systemic sclerosis does not usually happens in the early phase of the disease. It takes up to 4 years for patients to start experiencing softening of their skin. So most of these patients that are now being recruited into the studies, they are recruited at earlier stages in a hope that skin improvement will be linked to the medication effect rather than the natural progression of the skin disease.
So with all of this and all of this informations that sometimes conflicting, what is the best choice for treating the skin sclerosis, you think, beyond the inflammatory phase?
Now, if we go all back to the, recommendations, we all know that there are very few medications that were approved for the treatment of skin sclerosis, mainly methotrexate and cyclophosphamide. Mycophenolate is also another medications that joined, and hematopoietic stem cell transplant is one of the modalities. Now, putting all that together, when we see patients who are failing, for example, the oral conventional synthetic DMARDs, the next step is usually putting them on either cyclophosphamide or rituximab. But with the help of these new medications that we have, I think that medications like tocilizumab, medications like riociguat can be used as an off-label treatments for patients with systemic sclerosis, especially for the skin domain.
Okay, final question for you, Dr. Walid. In anti-PM SCL70 positive patients, is there other cardiovascular risk factors, and is it related to losing muscle bulk, resistance to therapy, or its side effects?
I'm not sure if I know the answer to this question, because the observation that was noted in this EULAR, it's actually for the first time that they noted that patients with anti-PM SCL positive antibodies, they usually show cardiovascular manifestations. This was not actually known before. So I think more research is needed in this field to be able to stratify or identify other risk factors for cardiopulmonary involvement in these patients.
Okay. I think this concludes our session. Thank you very much for your nice talk and very informative talk and effort, very fruitful, useful informations for all of us. I appreciate this, and thank you again to the Saudi Society of Rheumatology and Dr. Hanan for this wonderful and great effort that she's doing with her team. Thank you again, and I think we conclude this session.
Thank you.
Thank you so much.